let's look at organophosphate poisoning. So this, like the name entails, is just poisoning that is due to organophosphates. And these organophosphates are going to be common compounds found in insecticides. And so when you are looking at patients with organophosphate poisoning, it's important to kind of think about who would be the most people at risk of this. And so it would be important to find out if these people are living on a farm, a place that has got massive crops where insecticides are sprayed. They could have been exposed to organophosphates through that. You want to look out for children, since children are prone to ingesting things and playing with things that they shouldn't be. And lastly, it also wouldn't be uncommon for you to see a female, even a male at times, but all in all, people who are trying to take their lives through suicide attempts by taking these organophosphates. Okay, so let's look at the route of exposure, how the body is exposed to these organophosphates, and the three common ways that the body will be exposed to this will be through the GIT in terms of ingesting these organophosphates. It will be through the lungs, through inhalation, and also through the skin. So these organophosphates are lipophilic, and even in the management you have to have that in mind, since these organophosphates can penetrate through the skin. Okay, now we look at the pathophysiology, what's happening in this whole organophosphate poisoning. So let's look at the neuromuscular junction, where we are going to have two neurons. We have a presynaptic neuron and we have a postsynaptic neuron. So the presynaptic neuron is going to be releasing a neurotransmitter that is known as acetylcholine. And this neurotransmitter, at the level of the postsynaptic neuron, we are going to have receptors. Let's just call this an acetylcholine receptor. So when this acetylcholine comes on the receptor, the postsynaptic neuron will be stimulated. In this case, let's say the stimulation is 10 on. Now, this postsynaptic neuron shouldn't be forever be stimulated. There will be need for it to go off. And this is where the last player in this pathophysiology comes in, which is this guy I'll write as a star. This is acetylcholinesterase, which I'll just write as ACHE. So the role of acetylcholinesterase is going to break down this acetylcholine so that this postsynaptic neuron isn't forever being stimulated. Now, where does organophosphate poisoning come in? It comes in at the level of acetylcholinesterase. You can think of organophosphates as acetylcholinesterase inhibitors. They will inhibit this enzyme. If this enzyme hasn't been inhibited, it means that the acetylcholine is not going to be broken down. If it's not broken down, it means that the postsynaptic neuron is forever going to be stimulated. So think of it as forever being on. This is where organophosphate poisoning comes in. It's inhibiting the activity of acetylcholinesterase. With that being inhibited, it means acetylcholine isn't being broken down. If acetylcholine isn't being broken down, the postsynaptic neuron is being stimulated. And with that happening, we can now look at the clinical features, since our postsynaptic neuron is forever being stimulated. So we were looking at the acetylcholine receptors, and with these receptors, there are two which we are particularly interested in. So the two receptors will be the muscarinic receptors and the nicotinic receptors. A quick mnemonic for you to remember what will happen with the stimulation of these. When we're dealing with the muscarinic receptors, you should remember the mnemonic dumbbells. So the D stands for diarrhea, the U is for urination, the M is for meiosis, which is constriction of the pupil, the B is for bronchuria, which are just basically secretions in the lungs, bronchospasms, which is narrowing of airways in the lungs, and even hypotension, low BP. The E is for emesis or vomiting, the L is for lacrimation or tearing, and the S is for salivation. So already we can see that there's massive secretions that's happening. And so the thing that's going to kill patients the most when we're dealing with organophosphates is going to be these respiratory manifestations. Think about it, there's bronchuria, there's bronchospasms, and the salivation. It's easy for these secretions to go and fill up the lungs, and the whole respiration is going to be affected. So that's what's normally killing these patients. When it comes to the nicotinic, there's the Monday, Tuesday thing, but anyway, the things that will be there will be tachycardia, an increase in the BP. There will be sweating, mydriasis, which is the opposite of meiosis. There will be muscle weakness and muscle fasciculations. These are the nicotinic and those are the muscarinic. Again, the muscarinic will be easy to remember because of the dumbbells: diarrhea, urination, meiosis, bradycardia, bronchospasms, bronchuria, and low BP, emesis, lacrimation, salivation. Nicotinic, we've got tachycardia, hypertension, sweating, mydriasis, muscle weakness, muscle fasciculations. These are the nicotinic. And so this is also how these patients are going to present. Apart from this, there could also be CNS manifestations that can happen because of organophosphate poisoning. So things like altered mental status, patients presenting with seizures, and when bad, a coma is another thing that can be common. Okay, coming into the investigations, what to do with patients with this. Of course, we are interested in the acetylcholinesterase activity, and we are going to find that it is reduced to up to even less than 40% of what it should be. Another thing that would be important, like we said, respiratory manifestations are what kill these patients. So an ABG, arterial blood gas, is something that can be important. I think the next video will be on interpretation of ABGs. So ABGs will show respiratory acidosis. And of course, a chest x-ray, since these patients are at risk of having, again, respiratory manifestations. Aspirational pneumonia is a common thing that can be there. And anything else that you can think about. Okay, lastly, coming to the management of these patients. So the first thing first is you want to call for help. Since this is an emergency, you need multiple hands on deck, different people doing different things. And the next thing is remember the routes of exposure. So you need to protect yourself before engaging with these patients. You need to put on your safety boots, you need to put on gloves, your face mask, just because of the routes of exposure. Organophosphates can enter through the skin, so your skin needs to be protected. You can inhale them, so you need to do that. The next thing would be to wash down the patient or strip them. You want to ensure that there is no form of organophosphates on them, which can further lead to poisoning. And when you've done that, you can then commence the normal ABCs, ensuring that the airway is patent, ensuring there are no secretions, the breathing, the circulation, and so forth and so on. And lastly is on the antidotes when it comes to organophosphates. So the two antidotes that we are interested in, one is atropine, and the second one is pralidoxime. So this pralidoxime is sometimes written as 2-PAM. So let's start with atropine. We see what is happening with atropine. So back at the neuromuscular junction, we had a presynaptic neuron and a postsynaptic neuron. We have the receptor over there and we have acetylcholine. This is stimulating the postsynaptic neuron. So what atropine is coming to do is that it is fighting with acetylcholine for the receptor. It's more like displacing the acetylcholine. With the acetylcholine being displaced, it means that the receptor is free. If the receptor is free, it means that this postsynaptic neuron is no longer being stimulated. You know, the dumbbells, the muscarinic effects, and the nicotinic effects. Just displace the acetylcholine. If the acetylcholine is displaced, it means that those manifestations, that clinical manifestation, will not be found. And when those clinical manifestations, especially the respiration manifestations, and we are saying that we have reached a state of atropinization. So with that, we're going to see that the respiratory, the airway becomes clear. And remember, we had from the dumbbells with the B, we had hypotension. So ensure that the systolic blood pressure is above 80 millimeters. And when it comes to atropinization, when you're commencing atropine, say we are starting with 2 milligrams, you want to double the dose every 5 to 10 minutes until a state of atropinization has been reached, where we notice that the airway is clear and the BPs are going a little bit higher. So you start with 2 to 5 milligrams and you are doubling the dose until a state of atropinization has been reached. The other drug that we are interested in is the pralidoxime, which some brands will call it as 2-PAM. So again, we have our presynaptic neuron and we have our postsynaptic neuron. We have our receptor and we have our acetylcholine. And remember, organophosphates are binding towards this acetylcholinesterase. This is where organophosphates are coming in. So 2-palm works at the level of this bond over there. It breaks the bond between the acetylcholinesterase and the organophosphate. If this bond is broken, it then means that the acetylcholinesterase is free. If this enzyme is free, it then means it can do its job, which is to break down acetylcholine, thereby reducing the amount of acetylcholine present in the synaptic cleft. Again, I'll just repeat that. When we're dealing with 2-palm, 2-palm is basically working at the level of the acetylcholinesterase enzyme. We had the situation that was like this, and the postsynaptic neuron was turned on. However, this is bound to organophosphates, in this organophosphate poisoning. So 2-palm is coming in towards this bond, breaking it and freeing this organophosphate, this acetylcholinesterase, forgive me. With this acetylcholinesterase being freed, it then means that it's free to come and break down the acetylcholine, thereby turning off the postsynaptic neuron. Now, when we are dealing with pralidoxime, we have to remember that this can only be given within the first 24 to 48 hours. Let's stick to 24 hours. Within the first 24 hours. Why? Afterwards, this bond that is there between the acetylcholinesterase and this organophosphate, it becomes irreversible. It becomes a permanent bond. And so we want to do that as soon as possible. And that is on the 2 antidotes. And lastly, for the CNS manifestations, if there are seizures, diazepam could be a good drug to give. Alright, this has been organophosphate poisoning. Thank you for watching this video. Peace.